here from the CTAD clinic. My name is Dr. Mike Lloyd and I'm the clinic director. Today I'm going to be answering a question from one of the subscribers who contacted us and asked about an experience they had when in therapy. And the question was that they'd felt unable to speak about a certain subject and had wanted to go into therapy. The therapist was asking some questions and they couldn't speak and they felt blocked. And the question was, can my alters or can my internal system actually prevent me from speaking in therapy? The simple answer is yes, I believe that they can. This is something that I've seen in clinical practice a number of times over the years. It makes sense, realistically. If we're thinking about the process with which we actually offer therapy, the three-phase treatment model laid out within the theory of structural dissociation is for there to be three parts to the overall therapy process. The first is stabilisation, the second is trauma exploration, and the third is integration. Now, those terms can mean different things to different people, but the essence of it is that we don't do the trauma work until we've done the stabilisation. Therefore, the goal is to make therapy safe in order to understand how the impact of that trauma is within that person and that they can withstand the content of which that trauma might hold when discussing it or working through it with the therapist. This is true then for many aspects of dissociation. So we see it most often in OSDD or DID, other specified dissociative disorders, and dissociative identity disorder, but it's also very common in people who have depersonalisation as a key aspect of their dissociative experience. If we think that the alters are realistically emotional parts, they hold emotions, they hold the essence of that trauma, they hold the experience, they hold the memory, all of those things. So therefore, to approach an alter, to ask an alter effectively to disclose what they have is a choice that they might determine is not the right thing to do at that moment in time. There will be an understanding internally that the experience for the person when undergoing that trauma was that they couldn't manage, they couldn't cope, that it was too much for them, therefore the dissociation occurred. And then later in life, if the internal system believes that to disclose this information will be too much for the individual, even if they want to do it, the decision could be made to block that, to compartmentalise, to hold it back. Simply put, the internal system might not want certain things to be said until it feels safe to do so. That might be what the individual wants to do, but it does not mean it's what the internal system wants to do, and the internal system can often trump what the individual wants and withhold speech, literally prevent that person from being able to speak. When we're doing the assessment of dissociation, we look to see certain factors. Are internal systems able to speak? Are they able to influence behaviour? And can they generate emotions? Therefore, there's an already inbuilt mechanism for determining speech, emotions and behaviour, so prevention of speech seems completely fair enough as a thing to be able to be done. In addition, one of the things that can happen is the person is so desperate to want to tell their story to the therapist, they're not able to speak, so they pick up pen and paper. The therapist might say, hey, write this stuff down, and we can do it that way. The person then almost is incapable of being able to write. And I have seen people in the therapy room where they've picked up a pen and they cannot write. It's not that they don't know what to say or don't know how to write, it's that effectively they are being blocked. The depersonalisation effect is coming in, the body is not in the person's control, and they're not able to choose what they want to do. They know what they want to do, but they're not able to act that out. I suppose a way of thinking about it is that prevention of communication, therefore, is communication. It's the internal system, it's the brain's way of saying, not now. This is not the right time, this does not feel safe, this does not feel correct. It would feel maybe too intrusive or too shameful, or it's about releasing a secret that should not be told, possibly because of the legacy of an old threat much earlier in childhood about telling. So the fact that something is being prevented from being communicated is a communication that all is not well. That's what we have to listen to. So if the person isn't able to speak or write these things down, great. That's about stopping both between the person and the therapist and saying, okay, maybe now isn't the right time. Let's not push this, let's not force this agenda. We have to sit back, we have to be patient, we have to be calm, empathic and understanding and accept that the internal system does not want this to happen. How we then determine the way of reassuring that internal system becomes the key to ultimately working towards whatever that statement was or that memory was that was going to be disclosed. If we provide a safe environment, and this could be something that takes months and months and months, or weeks, or whatever it might be, if we're able to provide that safe environment that the internal system feels safe to be able to disclose, then that statement can be said. Sometimes it's about asking permission, it's about checking in, it's about signposting, the willingness to have a session to talk about these things. All of these factors and techniques become relevant. But the key characteristic, the absolute, is if you're not allowed to say something, it's better not to try. Sit, reassure, hold back and say, okay, I have listened, I'm not going to push this, we'll wait, maybe there'll be another time when everything is okay for me to be able to say it. And to try not to be too distressed about it. The more distressed the person becomes, the more likely it is that high levels of dissociation will then be brought in to manage that distress. And then we have that vicious cycle appearing. I like to look on it by thinking if it's meant to be said, it will be. Does it really matter whether it gets said today or next week or in a month? Ultimately, if the internal system believes it's correct to be said, it will be, and then it's just a matter of time and waiting. It can be very frustrating, it can be very difficult, especially if you have short-term therapies available. You might not have the time to do it, in which case accept that and find other things to be able to talk about. So I hope this has been useful. It's really great having a direct question like this from someone's clinical experience, and I hope I've been able to offer some understanding and some insight into what I think from my clinical practice is the answer to this, and a few things to be done if that actually takes place. So thank you very much for watching. Please do like and subscribe if you haven't already done so, and we will continue producing content, and I very much hope that it's useful to as many of you as it can be. So, in the meantime, before we have the next video, please do take great